This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Welcome to UCSF Mini Medical School, your brain in health and aging. I'm Michael Geschwind in the Department of Neurology, and I and my colleague, Dr. Jeffrey Gelfand, also in the Department of Neurology, will be presenting tonight, and I'll be directing the course. And these are my disclosures. You won't be tested on this, but just to let you know. This is the group that I work with at UCSF called the Memory and Aging Center. It's run by my mentor, Dr. Bruce Miller, who started this group. We're a group interested in studying how the brain works in health and in disease. Our main focus is using neurodegenerative brain diseases like Alzheimer's disease as a model for understanding how the brain works. We're about 170 people with over 30 faculty. Our faculty include neurologists, psychiatrists, geriatricians, nurses, pharmacists. We have statisticians, genetics counselor, social workers, IT group, who are even represented here tonight, and a whole cadre of very important clinical research assistants, research coordinators who help us run. And this is sort of what we do. We think of ourselves as being involved in these three areas. Patient care is our primary concern, but in order to develop and to provide the best patient care, we feel very importantly that we have to do research. Most of the patients we see in the clinic participate in our clinical research programs. Some of them are observational studies, some are treatment trials, and we're very involved in education. The psychiatry residents, the neurology residents, the medical students rotate with us. We have over 20 foreign visiting faculty here with us right now at our center from all over the world who come and learn from the people in our group. And so we really feel that all three of these are instrumental in order to provide the best medical care and to advance our understanding of neurologic disorders. We feel that we have to be involved in all of these areas. This is the outline of the 6 topics that we put together. The first tonight is on rapidly progressive dementia, from prion disorders to antibodies. And some of you might think, well, why are we talking about this first? And I'll try to tell you why. And one reason is because I'm directing the course and this is my area of research. But it does actually link these disorders that we're going to talk about have recently, over the past few years and even past few months, with research coming out of UCSF and elsewhere, have really shown that there's a link between these rare, rapidly progressive disorders and more common neurodegenerative diseases like Alzheimer's disease. So the outline of my talk tonight, well, I'm going to introduce some aspects of the brain. And I apologize to a majority of the audience because I understand that this is a very medically sophisticated audience. And I don't want to talk down to people. On the other hand, I don't want to lose people either. And so I apologize if the first few slides I talk about are obvious to many of you, but I'm sure for some of you it won't be. I'll talk about dementia, what it is, the different types, how we assess it. And then the last part of the talk, I'll briefly talk about rapidly progressive dementia, some of the disorders that I personally am interested in, and how they loop back and how they relate to our understanding of the more common, slower progressive dementias. So first I'd like to introduce the concept of probably the most important cell in the nervous system, the neuron. There are many other cells in the nervous system, as Dr. Gelfand will talk about to some extent, but this is sort of the key cell. And the neuron has a cell body. It has an axon, which is, think of it like the wiring. It's a wire that extends and connects to other cells, and it has synapses. And these synapses connect to synapses of other cells and to other cell bodies. In health, this neuron sends signals back and forth from the cell body to synapses. There are proteins that move back and forth, up and down the neuron. And in disease, these proteins begin to misfold. They get abnormal chemicals attached to them. They stop functioning. They accumulate. And they can build up in the cell body, in the axon, and the terminals. And then they can lead to disease, like Alzheimer's disease and Parkinson's disease. So you can get accumulation of different proteins. And that's going to be a key point tonight, how proteins can be responsible for causing disease, misshapen proteins. And I'll be alluding to often through the night, a lot of this work, the whole idea that a protein can cause disease, 20 years ago was a heretical notion. And Stan Prusner was one of the first people. He won the Nobel Prize in 1997 for his idea that a misshapen protein can be responsible for a brain disorder. And it can be responsible for a disorder that can occur spontaneously, can occur genetically, can be passed from family member to family member, and can be transmitted from person to person, an infectious disorder. And the idea that a protein could do all that at the time was a very heretical notion. And most people didn't believe it. I know of colleagues who were in the room when Dr. Prusner presented this theory at a major medical conference. He left the room and the whole room burst out laughing. And then about a decade later, he won the Nobel Prize for pushing forward the idea that a protein can cause disease. And we've only moved forward since then. Now it's looped back and we find out that this protein is not responsible only for the disease he was interested in, Jakob Creutzfeldt disease or Prions disease. Now proteins we know are involved in many disorders. And proteins accumulating in neurons and other cells can lead to disease. This is an image of what the brain looks like, looking at it from the side. The important point here is that there are different parts of the brain. There's the frontal lobes, shown here, a part here in pink or purple called the parietal lobe, and the occipital lobe here, the temporal lobe. This is the cerebellum, the brainstem, and we have much more refined breakdown of these regions, but when we think about the brain, we often think of it in anatomical regions and brain regions, and these are sort of the main crude regions. And each area has some function. So in historical neurology, one way we've discovered on how the brain works is somebody would have an injury to the brain and we would see what doesn't work. So somebody might have a brain injury. A famous case was a patient who was working on the railroad and a railroad tie exploded and it went right through his skull and it affected the frontal lobe. He lived because it went right through, but he had a complete change in personality. He was a different person. And so we know from that and other causes that the frontal lobes are very involved in our personality. They're also involved in our organizing, planning, multitasking. They're sort of the executive of the brain. The parietal lobes can be involved in visuospatial function, how we see things in space. They can be involved in movement. Occipital lobe in vision, temporal lobe in memory, language. Cerebellar helps refine our thinking, helps refine movement. The brainstem, the basic functions of life, breathing, heart rate, and many other things. And then we have even more refinement. So here we're looking at the brain cut right down the middle, and we're looking at the inside of the brain. And basically there's a lot on this slide, but each of the brain regions, we're showing the different areas and their function. So the parietal lobe being involved in movement, as I mentioned, vision here. The limbic system here, shown in this color, involved in memory, personality. So all these areas. But it's not just that each area has a discrete function. This was sort of an old way of thinking about the brain. Each area, discrete area, one function. And it's sort of an old idea that that functions were actually distributed throughout the brain, and there are networks. So there's a language network, there's a memory network, there are visual networks. There are networks in the brain that are occurring when you're just resting. And what I mean by network are areas that are functionally connected in time. So when, in this case, these are areas of the brain where there's activity going on simultaneously when somebody's doing a task, in this case, a memory task. So the temporal lobe, the parietal, and some of the frontal simultaneously are working. So different areas of the brain work together for certain functions. And in brain disorders, these networks, the language network, the vision network, whatever, they can get disrupted. And so these connections, these brain areas don't work synchronously like the way they should. And this had been an old concept in brain disease, and it's sort of something that we're coming back to now, and we're realizing how important these networks are in how the brain works. And you're going to hear more about that throughout the next series of lectures. This picture shows the brain, an actual photograph of the brain being cut sort of like a slice of bread. This is the top, this is the bottom, these are the temporal lobes. And the main point here is that on the surface of the brain, you can see it's gray. It's gray here. And then there's white areas here. We call this gray matter. And gray matter is where the neuron, the cell body of the neuron is. And the white matter are the axons and where a lot of the connections occur. And so you can think of the cell body here, and it's this neuron here might be connected to a neuron here, or it might be connected to neurons here, or to go down. So there are actually physical connections between nerve cells. And in the next series of lectures, and today's lecture, we'll be talking about diseases of the gray matter, the surface of the brain. There's also gray matter in the center, and also white matter diseases as well here, so the connections. And it's white because the axons, or the sort of the wiring of the brain, is covered by insulation, which is fat, and fat is white, and that's why it looks white when we look at it. So different brain MRI sequences can help us show the anatomy of the brain and abnormalities that occur. Brain MRI, magnetic resonance imaging, is an incredible tool that's been around for only about 30 or 40 years, and has really helped us greatly understand brain anatomy and brain function. So here's the front of the brain, the back of the brain, and this is an MRI image, so we're using actually, it's a magnet. It's not like an X-ray. This is a magnet. You can have multiple MRIs. There's no problem with having multiple MRIs. It's not like an X-ray. And you can see that this almost looks like that brain section. You can see there's gray matter, there's white matter. You can really tell the anatomy. And when we look at a brain MRI, we're looking to see the size of the brain. Is there shrinkage of the brain? And when there's shrinkage, the brain shrinks and it's filled up by this black, which is cerebral spinal fluid. So in this patient, there's a little bit of shrinkage. If this is probably a patient in their 70s, if we looked maybe 40 years before, there wouldn't be as much black. It would mostly be gray and the white. But over time, our brain naturally atrophies or shrinks because we lose cells. And then there are other sequences, in this case a sequence called FLAIR, that can show very specific abnormalities. This is a healthy 23-year-old, and this is a normal FLAIR MRI. But in a patient with multiple sclerosis who's 21, you can see these abnormal bright white areas. And these are not normal. And in this case, it happens to help with the diagnosing that the patient has multiple sclerosis. So MRI is very important for diagnosis. So now I'd like to change tack a little bit and talk about dementia. What is dementia? Dementia is an umbrella term. It's not a thing. It really describes a whole series of disorders, and it's an acquired, persistent intellectual impairment involving multiple cognitive domains. And a cognitive domain might include memory, language, visuospatial function, our ability to see things and interpret images, ability to navigate, our ability to organize, to plan. These are all cognitive functions. So you have to have a persistent, progressive deficit in these areas, and it has to be enough to cause a decline from a previous level of function. So that's dementia. So if somebody has a traumatic brain injury, a sudden onset, it's not progressive, and they don't progress from there, we might not necessarily cause that dementia. It might be another form of cognitive impairment. And dementia is a spectrum. So before one develops dementia, you might have cognitive problems, but you're not functionally impaired. You can still do everything you did before, but maybe not as well, and we call that mild cognitive impairment. And Dr. Kramer, Dr. Christine Yaffe are going to talk more about that in their session coming up. But just the idea that a change in cognition over the lifespan is usually a progressive process. And we move from normal function to mild cognitive impairment, eventually to dementia. And one thing that you'll be hearing about from the other speakers is that what we're trying to do now is we're trying to diagnose dementia at its earliest stages. There have been over 35 treatment trials for Alzheimer's disease. Until recently, all of them have failed. Recently, we've had 2 or 3 drugs that look actually pretty good, that they actually might show improvement, and that's because those trials have targeted people who are in the mild cognitive impairment stage in early Alzheimer's. And by the time we make the clear diagnosis, we now realize it's too late. So a lot of our efforts are trying to make early diagnosis. And dementia is not normal aging, and I try to show that here. Don't mind Grandpa, he thinks he's at Woodstock, and you can see him showing up naked here. So 40, 50 years ago, it was thought that everybody gets dementia. It's part of normal aging. We get lost, we forget things, and there is a level of cognitive decline that does occur as we age. Adam Ghazali here in the Department of Neurology, that's his interest, is studying normal cognitive function in healthy people. And he and others have shown that as we get older, certain functions do decline with aging. For instance, our ability to multitask and to our brain to filter out extraneous information. That's something that in our early 20s, it begins to decline after our early 20s. But you can still be healthy and normal without having dementia. So dementia is not normal aging. There are many causes of dementia. We tend to artificially divide dementia into what we call senile dementia, which is usually over the age of 65, or less than age 65, pre-senile dementia. And the major cause of dementia in older people over the age of 65 is Alzheimer's disease. And then there are other dementias, frontotemporal dementia, Parkinsonian dementias, some of the diseases I study, Jakob-Creutzfeldt disease, vascular dementia is very common. And then if we look under the age of 65, the proportion changes dramatically. Alzheimer's disease is less common, vascular disease is more common, and then we see other dementias. Frontotemporal dementia becomes more common. Some of the Parkinson's dementias, genetic dementias like Huntington's disease. This was Arlo Guthrie's disorder. And then other dementias, metabolic disorders, prion diseases, antibody-mediated encephalopathies that we'll discuss tonight. And this will be some of the focus for tonight, and these others will be talked about in future talks. So these are some of the major causes of dementia. Now, each of these neurodegenerative diseases is associated with certain protein abnormalities. And this is knowledge that's been accrued through years of laboratory research, through animal models, through doing autopsies on patients who've died from certain diseases, and discovering that in Alzheimer's disease, in the brain, there are accumulations of proteins. Amyloid, or A-beta-42, tau, these are 2 major proteins in Alzheimer's. In frontotemporal dementia, there are several proteins now identified. We used to think of it only as tau. Now we know tau, ubiquitin, TDP-43, and the list goes on, probably more than a half dozen proteins. Some we've just discovered in the past 2 or 3 years can cause frontotemporal dementia. Dementia with Lewy bodies is a sort of a disease that I consider a mix of Parkinson's and Alzheimer's in how it presents. But there are two main proteins, alpha-synuclein and A-beta-42. So the same protein that causes Alzheimer's disease also is involved in Lewy body. Tau is involved in frontotemporal dementia and in Alzheimer's. Parkinson's disease, alpha-synuclein. Huntington's disease, the protein huntingtin. And prion disease, the prion protein accumulates. And just as I'll use Alzheimer's disease as an example, but if we look at the brain under the microscope and apply different immunostains to brain tissue, we can detect amyloid plaques. So these are the plaques of Alzheimer's disease. This is the amyloid protein in dark here. And then here in the brown is immunostaining for the protein tau. So here we use antibodies that we apply to the brain, and we can detect accumulations of these abnormal proteins within nerve cells here. So Alzheimer's disease is a disorder of A-beta-42 and tau, which cause plaques and tangles. And these proteins don't usually localize randomly. It's not a random process. There tends to be certain regions of the brain that are preferentially affected where these proteins begin to accumulate. In some diseases, these proteins begin to accumulate in the brainstem. In Alzheimer's disease, there's probably some early involvement in the brainstem, but probably even earlier in part of the temporal lobe called the entorhinal cortex. And that's where the protein tau is early in the disease. As the disease progresses, the proteins spread back along a functionally connected network into the parietal cortex, and then in late stage of disease, the frontal part of the brain. And that's most common. There are some cases of Alzheimer's disease where actually the disease starts frontally. And in those cases, the disease sometimes might be mistaken for a different disorder, a frontotemporal dementia. Sometimes it starts in the occipital cortex, and we think of there are visual symptoms. But most commonly, it starts in this pathway. Along with the spread of these proteins, there's also dysfunction of the nerve cells, because these proteins are accumulating in the neuron. They're causing dysfunction of the nerve cell. Eventually, they'll cause so much dysfunction that that nerve cell dies. And when enough nerve cells dies, you'll get shrinkage of the brain, or atrophy is the medical term. And you can see here, this is, if we look at the brain, we cut the brain this way and look straight on, we can see, here's the brain, and this is the hippocampus, the area shown in blue here. And we can see that as the disease progresses, this area gets smaller. You can see that there's shrinkage, and it's being replaced by cerebrospinal fluid. And it almost looks like a hole in the brain because we've lost nerve cells. So this is something when we do an MRI in the brain, we're looking to see the pattern of atrophy. Is the pattern of atrophy consistent with Alzheimer's disease? And this is something that occurs over time. Early in the disease, we might not see much atrophy. So some key concepts, just to reiterate some of what I've said. Dementia is not a specific diagnosis. It's an umbrella term that describes somebody's decline in cognition in multiple cognitive domains to the point where they no longer are able to function the way they used to. And there are many disorders that can cause dementia. There are neurodegenerative diseases. And most of the neurodegenerative diseases actually are disorders of proteins that are misfolding. When one protein misfolds, that misfolded form becomes a template, and it causes other nearby normal-shaped proteins to also misfold. And then this misfolding spreads from cell to cell along functionally connected networks, and it spreads throughout the brain. And usually this process takes years. That's what typical Alzheimer's disease would do. And this process, it affects focal brain regions, but it does so along connected networks. So circuits get disrupted. And dementia, and those are neurodegenerative diseases, but there are other causes of dementia, as Dr. Gelfand and I will discuss, not just neurodegenerative diseases. So now I'd like to tell you about how do we approach a patient who comes to us with cognitive complaints or neurologic symptoms. Well, the first thing we do is we need to get the data. We need to get information. And so we do an extensive review of their symptoms. What have they noticed? In our clinic, it's very important that a loved one comes with the patient, usually a spouse, a child, a caregiver, somebody who can go back and tell us what the history was, when the first symptom was. And the first symptom for us is often the key. And one of the things that makes us a tertiary care center is that we spend a lot of time with patients. We have to, because we realize that spending time to get a really good history is what is one of the main keys to diagnosis. So a lot of places, if you go to see a neurologist, you spend 15, 20 minutes. And our first visit with patients usually is 8 hours. You're there for an 8-hour visit, and we do a very comprehensive. Sometimes it's 2 hours, but even then, that's usually much longer. And that enables us to really feel very confident of the diagnosis when we're done. We get a family medical history. Often some disorders are passed down in the family, or they're familial risk factors that are genetic risk factors. We get social history. Did they have any exposures? What kind of work did they do? What's their level of education? Were they exposed? Did they work on a farm and exposed to certain chemicals? Did they drink a lot? Did they take drugs? Have they had a history of head trauma? All these things that can affect how we evaluate a patient. Getting a medication history is so important. We have a full-time pharmacist on staff, unfortunately just retired, but for 15 years we've had a full-time pharmacist who helped us review patient medications, herbals, non-herbals, because often medication can cause problems, both cognitively and otherwise. And then we do a very detailed examination of the body, of the neurologic system. We do pen and paper or computer testing, trying to evaluate different parts of the brain. Each lobe of the brain, different networks are evaluated through cognitive testing. So we get a picture of what parts of the body and the brain are not working right. And then we look at relevant diagnostic tests that have been done. We look at blood tests, urine, imaging of the body or the brain. We look at the results of spinal fluid, electroencephalogram or brainwave tests. And these are just to name a few. And based on this information, we can then usually localize the problem. The patient's having visual symptoms that maybe we're thinking of the occipital cortex. They're having a lot of short-term memory problems. The temporal lobes of the hippocampus are where we store short-term memory. Those might be involved. And knowing which areas of the brain involved tells us which networks, and a network can tell us what are the likely diseases that might be the cause of that. And so based on the networks involved, the brain regions, we come up with what we call the differential, a list of likely diagnoses that can present in this way, and this we know based on our experience, essentially. And then we also like to include things that maybe are or are not as likely, but are urgent, things where we could treat them, or if we don't diagnose them quickly, a patient may progress very quickly or might even die. So we create a differential, and the differential includes the most likely causes, but also causes that we don't want to miss, like a vitamin deficiency, something that's completely treatable, or a medication that somebody's on that's causing problems. And then based on this differential, we might say, well, we need some additional tests to rule in one disease or rule out another disease, or, and eventually this will help come up with a most likely diagnosis. And then once we make that diagnosis, then we begin to initiate a treatment plan, assuming that there are treatments. And even if we can't treat the underlying disease, most of the time we can at least treat the symptoms. When I started my training in neurology, a lot of people said, why are you going to neurology? All we do in neurology is diagnose. We don't treat. Well, at the same time I was doing my clinical work, I was also doing a PhD in gene therapy, and I realized that we were in the era of being able to treat brain diseases. Just like 40 years ago, we couldn't treat heart disease, and now it's relatively easy to treat heart disease. The brain is sort of the organ in which we're going to be able to treat over the next coming years. And for me, this is a very exciting area, and that's why I went into the field of neurology, because I enjoy the diagnosis. It's sort of like a mystery for me. Every patient I see is trying to figure out what's going on, but also the idea that we're going to be able to treat and cure patients. That, for me, holds great promise and is really exciting time to be in this field. So I'd like to take you now through sort of a thought process when we see a patient, particularly with cognitive complaints. So one of the things we want to know about is, what's the time course? Have the symptoms been going on for 3 years, 5 years? Or has it been very fast? Was the patient normal 3 months ago and now can barely think, can't work, has trouble using the computer? Or was it sudden onset? They were normal one day and then by nightfall they couldn't function. And each of these can point to different types of processes. A slow process might be a neurodegenerative disease, like Alzheimer's disease. A faster process over weeks or months might be an infection, might be an autoimmune disorder, might be Prion disease, which is a rapid form of neurodegenerative disease. If it's sudden onset, we might think of something like a stroke or maybe a seizure. So if a patient comes to me, he's in his mid to late 70s, he's had 3 years of memory problems, he's forgetting conversations, he's been forgetting what he's told, he can't remember appointments. We'd think about a slowly progressive neurodegenerative disease. Maybe this patient is in early stages of Alzheimer's. Maybe then I find out that the patient has been having some movement problems. They've developed some Parkinsonism. They're moving slower. Oh, and they're having some visual hallucinations. At night, they see little creatures and little people around the house that aren't there. All of a sudden, that points me to a different diagnosis, dementia with Lewy bodies. So getting the history, getting the time course can be very helpful. So we identify the key symptoms, we find and the findings on neurologic exam. That helps us localize what parts of the brain are affected. And then it's sort of pattern recognition. We see a pattern, and based on our experience, we know, aha, this is dementia with Lewy bodies. Oh, this is frontotemporal dementia. And part of this is experience and expertise in seeing a lot of these disorders. And we come up with a list of likely diagnoses, and we group them not only by the likelihood of diagnosis, but how urgent it is. There are some disorders, as I mentioned, that are treatable. We need to diagnose them very quickly. And Occam's razor is very important. Usually, we like to think of a unifying diagnosis. If a patient has multiple symptoms, we usually like to try to find one cause that can explain all the symptoms, as opposed to 3 different causes for 3 different symptoms. For example, a patient comes to us and he has some weakness on one side, he's having some memory complaints, and he has a history of cancer. Well, one thing we're going to want to do, because it's urgent and because it's high in the likelihood, is maybe this patient has had cancer that's spread to the brain and it's causing multiple focal areas of neurologic dysfunction. So we certainly want to rule out, we might think of Alzheimer's, but we want to rule out other disorders that can mimic it. So even if we diagnose Alzheimer's disease, we're usually going to send a workup for treatable causes of cognitive impairment, like vitamin deficiency. We're going to check blood count, electrolytes, all things that might cause cognitive impairment. And in general, there's this idea in medicine that when you hear hoofbeats, first think of horses, not of zebras. So common things are common. Now, I've sort of made my career by diagnosing zebras, but it turns out that the zebras that I've diagnosed now have come full circle, and it turns out that a lot of the zebras that I study are very related to the more common diseases. And that's something I hope you'll get out of this lecture. So there's a mnemonic that I like to use when working up any patient with dementia. Working up a patient with dementia, particularly rapidly progressive dementia, there are so many causes of dementia. And I like to have a very systematic approach. And I actually, every time I'm seeing a patient and I have students or residents that I'm teaching, I actually go up to the whiteboard or chalkboard and I write down this mnemonic, vitamins. And I use this to think of all the different possible causes of cognitive impairment. Vascular causes such as strokes, inflammation of the vessels or vasculitis, infections, HIV, Lyme, encephalitis. These are, I try to think of all these things, particularly things that are treatable. Now HIV is treatable. Lyme disease, funguses, parasites. Dr. Gelfand will be talking more about some of these. Toxic metabolic conditions, we always want to review the medications. In an elderly person, often the thing that's causing their cognitive impairment is either over-medication or urinary tract infection or pneumonia on top of somebody who's elderly. And then autoimmune diseases, that's always in our differential. This is a big area of research that Dr. Gelfand and I work in. Could it be a cancer, either a known cancer or an undiagnosed cancer? Could there medicines, could it be iatrogenic or caused by something that we in the medical community have done to the patient unintentionally? Could it be a neurodegenerative disease? Could it be something systemic? Could there be a mass in the brain? Could there be seizures? Could there be something structural that's developed over time? So now I'd like to talk about the area of rapidly progressive dementias. And for rapidly progressive dementias, most of the neurodegenerative diseases, most dementias progress over years. A patient comes to us, we find out that when we get a really good history, we find out symptoms have been going on for 3-5 years, slowly progressive, but only now has the patient really become functionally impaired, and that's why they're coming in to see us. On the other hand, some patients come in and the family is really insistent. They were normal 3 months ago, and now they're not normal. Or a year ago they were working, now they can't work. And we consider that a rapidly progressive dementia. I use the definition from onset to dementia in less than 1 to 2 years. More often, most of our patients, though, are weeks to months from onset to dementia. The prototypical rapidly progressive dementia are prion diseases, and the prototypical one is called Jakob-Creutzfeldt disease. And prions are proteins that cause prion diseases, and they were discovered by Stan Prusner here at UCSF. As I mentioned, he won the Nobel Prize for this, and he got the name from, he identified a protein in animals that had prion disease. At the time, we didn't know if they had a disease, which he later called prion disease, but he found proteins in the animals that were sick with disease, but not in healthy animals. And these proteins were transmissible. He could take the proteins, extract them from the brain, put them in the brain of into another animal's brain, and that animal would get sick. So he called these diseases, or these proteins, proteinaceous infectious particles. And he took PRO and IN from this, and he came up with the term prion. He spelled it a little differently, but so we call them prion because proin didn't sound as good as prion. And even though prion diseases are very rare, as I'll mention in a minute, we now know that this is a model for most other neurodegenerative diseases. And this really has only come to the forefront in the past 10 years. And a lot of the work took place here at UCSF to discover that. So there are prion diseases of animals and of humans. Scrapie is one of the first known prion diseases. It occurs in sheep and goats. And it's called scrapie because the animals get itchy and they actually scrape their fur up against fences and trees, and they scrape off. And then bovine spongiform encephalopathy, or mad cow disease, is also a prion disease, as most of you I'm sure have heard of. There was an epidemic in the United Kingdom in the mid-'80s, but there have been isolated cases in North America. There are 15 cases identified in Canada, 4 to 5 in North America, and throughout the world. But fortunately, we haven't had epidemics elsewhere, like in the UK. Chronic wasting disease, well, that is an epidemic in the United States, first identified here. It's in mule deer, elk, moose in North America, mostly in the Wyoming, Colorado area up through Canada, but it's now been identified even in New York State, Wisconsin, and then transmissible mink encephalopathy. So these are just some of the animal prion diseases. And then there are human prion diseases. We divide into 3 forms based on how they occur. Sporadic or spontaneous, we call Jakob-Creutzfeldt disease or Creutzfeldt-Jakob, CJD. Genetic prion diseases, and these are the most common. 85 to 90% of all human prion diseases occur spontaneously, meaning we don't know what causes them. It's presumed that it's a spontaneous event, just like Alzheimer's, Parkinson's are spontaneous diseases most of the time. But 10 to 15% of human prion diseases are genetic, meaning there's a mutation in the gene that encodes the human prion protein that makes that protein more susceptible to misfolding, and that gene is passed down from parent to child, with a 50% likelihood of each child getting that bad gene. And we divide the genetic forms into different forms based on their clinical and their pathologic symptoms. And then there are acquired prion diseases. These usually occur through medical mistakes or other causes. Kuru, this was a prion disease of the Faroe ethnic group in Papua New Guinea. And in this tribe, the tribal members would honor their deceased relatives by eating them. And the women and children would be the ones who did participate in these feasts. And unfortunately, the women and children were coming down with a shaking, trembling disease. Late in the disease would get dementia, usually 1.5 years, 2 to 3 years. And kuru means to shake or tremble in the Faroe language. And Carlton Gajusek won the Nobel Prize for discovering this disease. And at the time, he thought it was due to a virus because multiple family members would get it. He thought it was a virus that was passed down. But people like Stan Prusiner and others later identified that it wasn't a virus, but a protein. And then variant CJD, this is due to exposure to bovine spongiform encephalopathy. And in most cases, people have consumed BSE. But there are also some cases now that occur through blood transmission. So a patient who has variant CJD, probably from having consumed BSE, the prions actually are in the blood, and if they give a blood donation, people can get the blood and can get the disease. And that's why in the U.S. we don't take blood. We don't take blood from people who've lived in the UK for certain periods of time, and why in the UK all their blood products are from the United States, because we don't have much BSE here. And then iatrogenic causes, medical mistakes. Sometimes people have had brain surgery or brain procedures who unknowingly had prion disease, and prions are proteins. And if you treat surgical equipment in a way that that removes viruses and bacteria, you're not removing all protein. And even if you clean the equipment, the protein is still there, and you can transmit the disease. Fortunately, these are very rare cases, and now that we know about them, they're much less common to occur. So the idea is in prion disease that the prion protein is a normal protein. All of us have prion proteins, mostly in our brain, and it has a certain shape here, shown in red and a little bit of blue. There's a coiled shape in red, and then there's a beta-pleated sheet structure shown in blue. The abnormal form of the protein, called prion-related protein scrapie, from the protein of scrapie of sheep and goats, has a very different shape. It can have the exact same amino acid structure, but the conformation is different. In genetic prion disease, this conformation occurs, this change occurs, because there's an error, a genetic mutation that causes this protein to be more susceptible to misfolding. In spontaneous prion disease, or sporadic, this protein spontaneously misfolds into the abnormal form. And the working model of Dr. Prusiner is that the normal and the abnormal protein come together. And presumably, there's another protein called protein X that helps facilitate this. I love that name, very clever. And when these two come together, the normal one now becomes abnormally shaped. And so you start with one of each, and now you have two abnormal. And then these two abnormal come in contact with two more normal ones, and now you have two become 4, 4 become 8. It's an exponential process. And in prion disease, it occurs very rapidly and easily, which is why prion diseases are rather fast. We now know that this model probably is the way Alzheimer's and Parkinson's spreads within the brain, but it's just a much slower process, which is why those diseases last for years, and they're probably going on for decades. So for sporadic CJD, people tend to get the disease in their late 60s, but there's a wide range. We've diagnosed a 12-year-old and then people in their 90s, but it tends to occur in the late 60s. It's everyone who's ever been diagnosed with it, unfortunately, has died. Survival is usually only a matter of months, and 90% of patients live less than a year. The incidence is about 1.5 per million per year. But a person's lifetime risk of dying from CJD is much higher than that. So if you take all deaths from in the country and divide them, if you use that in the denominator and the numerator of all deaths from CJD, and you look at most people will live through their late 60s, this is what we think a person's lifetime risk, 1 in the 10,000s of dying from prion disease. And there are probably about 300 cases in the US per year and about 30 in California. And this is a complicated slide, but the point here is that how do we diagnose the disease? Well, in yellow, I've shown you some of there are a constellation of symptoms. WHO came up with some criteria. We created some in 2007. The Europeans modeled some of theirs based on ours and the WHO. And there are also ancillary tests like an EEG, spinal fluid. We added brain MRI. We found that to be very helpful. So I just wanted to briefly present a patient. This is a patient who, he was a park ranger, and he did a lot of work at the computer. He came in with 3 months of confusion, forgetfulness, vision, and word-finding problems. He was getting lost in his house. He came home one day and he told his wife, "Honey, I can see the words on the computer, but I don't know what they mean anymore." So he was having a language problem. One day he came home and said, "Honey, my hands, I look at them and they seem grossly enlarged." And as a neurologist, I know that the language problems are in the left side of the brain, that this visual distortion happens to be in the junction of the temporal and parietal lobes more on the right than the left. So I was already beginning to think about where the disease was occurring. He had developed more language trouble, developed some motor problems, couldn't figure out how to use utensils. By month 3, he couldn't even be left alone. A lot of personality changes, too. I'll skip his exam, but to say that when we looked at his brain MRI, anything bright on this sequence is abnormal. And just as we expected, the parietal lobes were involved. This would be visual spatial function, and this is the left side. It's reversed here. And this would be where language is. So, and then we can also use an AD sequence here. Anything that looks dark, it's hard to see in this light. But the areas that are bright here are dark here. And this is very helpful for diagnosing prion disease. And a lot of the work at our center here has helped show the utility of this technique for diagnosing this disease. We've had, one of the ways we became a center for prion disease is that when I first came to UCSF, shortly afterwards, Stan Prusner's lab came up with a drug that seemed to help in a cell culture or petri dish model of prion disease. And this went into the press. We were contacted all over the world by patients with many forms of rapidly progressive dementia who were thought to have prion disease contacted us. We reviewed their cases. We diagnosed about a third of them with CJD by record review, and then a quarter we felt, even though their doctors diagnosed them with CJD, we felt did not have CJD. And then we felt that also, and then when patients came, about a quarter of these patients came to UCSF for evaluation, and what we found is that over 40% of them were thought to have, many of whom were thought to have prion disease, didn't. They had another form of neurodegenerative disease. And when we looked at that, we found out, for those who didn't have prion disease, we found out that about 40% of them had another neurodegenerative diseases like Alzheimer's or Parkinson's, Lewy body dementia, frontotemporal dementia, which would have very different prognosis and possible treatments. And then in yellow, I'm showing all the treatable causes of dementia. So many of these patients were thought to have a uniformly fatal disease, but when we evaluated them, in these cases, we found something treatable. And Dr. Gelfand will talk about these in a few minutes. My colleagues at other centers have now set up rapidly progressive dementia centers similar to our own, and they found similar findings in terms of the other causes of rapidly progressive dementia. So just to give another example, using my mnemonic of working up a patient, this is a patient who was referred to us as having CJD or prion disease. He was a gentleman with a rapidly progressive dementia that had been going on for only 2 months. He was confused. He had ataxia, like he was drunk. He had trouble coordinating. He had some Parkinsonism, slowed movement. He had cognitive dysfunction. And he was actually in hospice on a feeding tube, and the family was going to withdraw the feeding tube and let him pass. And then they sent us copies of his brain MRI, and we saw this, and based on this, we saw that there was it was dark here on this sequence, and when we gave contrast to the patient, this lit up, showing that there was a breakdown in the blood-brain barrier. And right there, that told us that that doesn't happen in prion disease. Our experience tells us otherwise. And also, it looked like there was some swelling going on in the brain. And so we knew that this wasn't prion disease, even though his symptoms could be explained by these anatomical involvement. And we insisted on getting a brain biopsy, and sure enough, it turned out to be a lymphoma that attacked the nervous system. He was treated and walked out of the hospital. So this is part of why we do extensive workups on our patients. And so to sort of finish up, this idea that this mechanism of a protein causing disease, a protein misfolding, now has been linked to many other neurodegenerative diseases. And I give credit to Mark Diamond, who did his medical training here, was our neurology resident, faculty member, and he actually found that the protein tau, one of the proteins involved in Alzheimer's and frontotemporal dementia, he showed in cell culture that it could spread from cell to cell in a prion-like manner, and it can cause misfolding of other tau proteins. Since then, he and others have shown that in animal models, mouse models, that A-beta 42, tau, alpha-synuclein, the proteins involved in other neurodegenerative diseases, can also spread in the brain in a prion-like manner. You can extract the protein from the brain of a mouse, inject it into another mouse, and that protein will spread in the brain and often give that mouse a neurodegenerative disease. And now there's increasing evidence, some very exciting papers that talked about in the New York Times and others, that have shown that even in humans now, we have examples where these other diseases, multiple system atrophy, Alzheimer's disease, might spread in humans in a prion-like manner. Some people now are calling all these diseases prion diseases. I personally don't call them that because I call them prion-like diseases. They're slower. They can spread within the brain, but they don't occur over weeks to months. They occur over many, many years. And so I differentiate them. But the important thing is that we now have a common mechanism linking these diseases. So treatments for one disease might help with treatments for the other disease. So some final thoughts on my part of the talk. Dementia is not normal aging. It might be preventable and possibly treatable depending on what is the cause. And that neurodegenerative diseases are based on specific protein abnormalities which spread through the brain along functionally connected networks. And the diagnosis, how we make a diagnosis, it's part science. We use data, we use the symptoms, we get a good history, we look at lab results, MRI, but it's part an art too. There's pattern recognition involved. We see a pattern of symptoms and findings, aha, based on my experience, this is what we think. So it's part science, part art. Brain imaging has been critical for us in understanding and diagnosing disease. And most of what I've been able to tell you, most of what we know about brain disease is through research. Patients who've passed away from neurodegenerative diseases or they've been involved, we follow them throughout the course. When they no longer need their brain, they give it to us for research. And that's really been instrumental in us understanding these diseases. And my hope is that through this course, you will develop a better understanding of how the brain works, both in health and in disease. I want to thank my colleagues at the Memory and Aging Center. This is our neuroscience building, neurology building directly across the way. Our group's on the bottom floor, and part of the second floor. Dr. Gelfand is on the second floor. Dr. Prusner's group's on the third floor, and then others are on these floors as well. And then the work, all of the work I presented to you has been very collaborative, both people at my own institution, Dr. Prusner's laboratory, our patients, our patient foundations, and collaborators both at UCSF and at other institutions. And most of my funding has been through the National Institute of Health, as well as some families who've donated very kindly to our research. And thank you. So I'm very pleased to introduce Dr. Gelfand, who's an assistant professor of neurology. He's in the neuroimmunology group here. Dr. Gelfand studied at Princeton and then went to medical school at a place in Cambridge, Harvard, yeah, that's it. and then was wise to come here for his neurology residency and fellowship, and is now a distinguished member of our faculty. He's won numerous teaching awards. He's won some other awards as well. He and I started an autoimmune clinic a few years ago because we thought that combining our expertise, he in neuroimmunology, myself as a behavioral neurologist, we would better be able to diagnose and treat people with antibody-mediated disorders, which he's going to tell you about. Jeff.
Great. Thank you. Good evening, everybody. So these are my disclosures. I also receive funding through the NIH and through additional mechanisms as well. And I'm going to talk about some off-label treatments for these disorders. Some rapidly progressive dementias, as Dr. Geschwind said, are autoimmune and are readily treatable. Antibodies can target neurons and cause brain dysfunction. This is a key insight, a real major discovery over the last decade that has changed the way we think about treating these kind of neurological disorders. I'm going to talk about that in detail. And antibody-mediated brain disorders provide fascinating insights about how the brain works. And I also think that by studying how people recover from brain dysfunction, we can also gain some fascinating insights about not just how the brain works in health and disease, but also how it recovers. So what is an antibody? We use that term a lot now for understanding our immune system, for understanding medicines. Dr. Geschwind mentioned we used antibodies to stain pathology. I wanted to actually spend a little bit of time talking about what these terms mean. An antibody is a protein that recognizes and binds to other proteins, in particular what we would call a target protein. And the term of art for that is an antigen. And you can think of this like a puzzle piece, where there are millions of antibodies, and they all have different combinations, and only some will have the right key, the right piece of the puzzle that fits. But when it binds, it then can call in additional troops and make more antibodies of that kind, and then you actually can target that protein of interest. So that's actually how our immune system fights infection. It's how it fights cancers. It's how it fights other injuries. And more now, with advances in biology, you can design antibodies to even be medicines. So if you say there's a bad protein, you can design an antibody to bind the bad protein and get rid of it. And there are many medicines now, some of you may even be on them. We call them biologics because they're antibodies that are actually antibodies. Usually we give them as shots or we infuse them, and they target antibodies. Examples of this would be antibodies that target certain immune cells to lower the immune system. And these are the mainstays now in treating diseases like multiple sclerosis, treating rheumatologic diseases, many cancers. So antibodies can be our friend. Antibodies can also be our enemy. And this is when sometimes our own immune system can turn on itself. It thinks, it doesn't think, but you can imagine that it actually, it's as if it's fighting an infection, but it turns on itself and attacks our own body. And when it does that, that's aberrant inflammation. It's too much inflammation. It's misdirected inflammation. And we call that autoimmunity. And there are now examples of this in nearly every aspect of medicine where we know that autoimmune diseases can cause problems. And what we're learning about now is that there are autoimmune dementias, and that these are very, very important because we can actually understand how they function, because many of these antibodies target particular receptors, particular targets in the brain. So we learn a lot about how the brain works. But even more importantly, we can treat these if we make the diagnosis correctly and timely enough. So just a couple of other terms of art. We use the word encephalopathy. Encephalo means brain. Apathy means something going wrong with it. So this is something wrong with the brain. It's a pretty generic term. But we use it to mean an impairment of brain structure or function. Often you can imagine that this term will be used when a patient comes in with confusion, with altered consciousness, with a behavioral change. This can occur in dementia, but there are other potential causes. Sometimes we term this delirium. So if you took a bunch of medicines or drugs, for example, that altered the way your brain thought and you got a bit confused. That would be an encephalopathy. That's not necessarily a dementia. I mean, that can get better pretty quickly. But in that moment, when the brain is not working right, when there's an alteration of brain function, we would call that an encephalopathy. And some of these encephalopathies can persist and may actually be a form of dementia. Encephalitis, remember encephalo means brain, itis means inflammation. So brain inflammation is exactly what it says, brain inflammation. And there are many potential causes of brain inflammation. Sometimes it's infection, sometimes it's autoimmune, sometimes there are other reasons that the immune system gets secondarily activated. And this is similar to a term you might have also heard, meningitis. The meninges are the saran wrap-like coverings around the brain, and when those get inflamed, itis, remember, it means inflammation. Meningitis is inflammation of the meninges. You get a disorder of the meninges. That can also be infectious, and you may have heard of outbreaks of meningitis. But there again can be autoimmune causes, and you can have combinations of these. You can have meningoencephalitis. So if you have both meningitis and encephalitis, we call that meningoencephalitis. If there's myelitis, myelo means spinal cord, itis means inflammation, you can have a meningomyelitis, inflammation of the spinal cord and the meninges. So we use those terms to refer to the area of inflammation. So I'm going to zoom in on encephalitis. This is a major public health problem. In just 1 year alone, and this is data from 2010 that was published by the CDC, the Centers for Disease Control, in just hospital costs alone, this country spent $2 billion on encephalitis. That doesn't include rehab, it doesn't include lost productivity, disability. It's a major public health problem. There were over 260,000 hospitalizations over a 12-year period. That translates to about 20,000 hospitalizations a year. And up to 5 to 15% of cases are fatal. The incidence, if you remember the incidence of Creutzfeldt-Jakob disease, of the Prion disease, was 1 in about 1.5 million. The incidence of encephalitis is on the order of 5 to 6 per 100,000. And this number is similar in other developed countries in Europe and also in Australia. When we approach the syndrome of encephalitis, this is how we as doctors think about it. As Dr. Geschwind said, we like to group things based on how common they are, what's likely, what's most likely to be the right answer, but also what's life-threatening and time-sensitive. And so by far, the most time-sensitive concern would be an infectious cause. Then the other major category would be non-infectious, primary inflammatory, and those are autoimmune, or sometimes they're cancer-associated inflammation. We call that paraneoplastic. Neoplasm means cancer, para means cancer-associated. So it's not actually the cancer in the brain, it's that there's an inflammation fighting the cancer that then gets misdirected to target the brain as if it's trying to fight the cancer. We call that paraneoplastic inflammation. And then, of course, there are other causes of encephalopathy, that whole differential diagnostic list that Dr. Geschwind taught about earlier today. Even in the 21st century, at the top hospitals in the US and in Europe, up to 30 to 50% of cases of encephalitis go unsolved. We know that they're encephalitis, we just can't put our finger on what exactly caused it. Typically, we think of these as either infectious, paraneoplastic, or autoimmune, but really, this is the major category, the unknown, or what we might call, in medical terms, idiopathic, meaning we just haven't figured it out yet, but we're going to keep trying. This is a summary of some major studies in the medical literature, and what I want to draw your attention to is that even over the past decade, the number of unsolved cases, has come down from about 2/3 to a half to more like 1/3. So I do think we're making progress, but we have a long way to go. Why is it so hard? There are over 100 infectious agents, 100 potential pathogens that can cause encephalitis in humans alone. That's a lot of diseases to think about and a lot to be able to test for. And the problem is that infectious disease testing is limited by technical challenges. You have to come up with tests for each of these diseases. Often the tissue that we have available, if we do a spinal tap to get spinal fluid, we can get a certain number of milliliters, but it's not an endless supply unless we keep doing the procedure over and over again. So often we have to prioritize which tests we're going to do. And each of these tests can cost a lot of money. And currently you have to have a targeted approach, which means that you have to say, I think it might be one of these infections, so I'm going to send the test for infection 1, for infection 2, for infection 3, and then you have to get all the results back. And in real life, this often means putting a spreadsheet together and keeping track of all the results. And this is what we do for these complex diagnostic questions. The other reason this is hard is that many previously unsolved cases are increasingly recognized as autoimmune. This is actually an exciting part because it means that there's really an answer for some of these, and many of these new syndromes are still actively being discovered. Dr. Geschwind was talking about one of his reasons for getting so excited about becoming a neurologist, that this was really this is going to be the century of the brain, is what people talk about. We're going to develop treatments. In addition to developing treatments, we're still discovering new diseases in the 21st century, and I think that's pretty remarkable. So when I approach a patient who might have an infectious cause of encephalitis, you first use your clinical judgment, and then you test for specific microbes, specific infectious agents, and we have special ways of doing this, looking at trying to match genetic signals. We look for antibodies. We try to grow the pathogen. And as a last resort, sometimes we do a biopsy of brain tissue to get an answer, the same way that we might do that of the kidney or the liver or the lung. There's a new technology that's coming out of UCSF and other institutions that I think is extremely exciting and has a lot of potential for changing the way that we think about this. And this is called unbiased next-generation metagenomic sequencing. And the reason it's unbiased is that you don't have to know what you're looking for on the front end. The real art is to figure out what it all means on the back end. And the analogy here is that several years ago, if you wanted to do genetic testing, you would need to say, I wonder if a patient has something wrong with this particular gene. Now we're able to sequence the entire human genome at remarkably low costs. And we can do that for patients. And so the art is actually trying to figure out what it all means on the back end when there are multiple mutations and say, could any of these be disease causing? Here, the analogy is that we're going to take a tissue sample, in this case spinal fluid, which is normally not it's really sterile. There's not infectious agents usually present in the spinal fluid. That's unlike, for example, our saliva or our sputum or our skin, where we have many bacteria and viruses that just live there normally, commensally. Same with our gut. The spinal fluid doesn't usually have that. So if we take the spinal fluid, we use this technology where we can amplify the genetic signals there, the genetic material there, the RNA, and amplify it over and over again. We sequence it millions of times over using these machines, the same machines that we can do to sequence the human genome. And then we try to figure out what it all means. We take the sequence, we get rid of everything that's human, and then you use the remainder that's not human and match it with the genomes of known infectious organisms. And then you use computers and you say, could any of this be the answer that we've been looking for? And this is work that my colleagues, Dr. Charles Chu here, Dr. Joe DeRisi, Dr. Michael Wilson, have really done amazing work putting this science forward. And an example of that is a paper that was published in the New England Journal just this past year by my colleague, Dr. Wilson and Dr. DeRisi and Dr. Chu, where there was a young boy who had an immunodeficiency disorder that put him at risk of both infection and autoimmunity. And he unfortunately developed a meningoencephalitis, inflammation of the brain and of the meninges. And despite the doctor's best efforts and giving him many different kinds of medicines to treat infection, he continued to get worse. And then they said, could this be an autoimmune disease? And they gave him medicines to lower the immune system. And he got even worse. And he was dying. And they were able, under a research protocol, to send spinal fluid to San Francisco And within just a couple of days, using that pipeline that I showed you, we're able to identify that there was a bacteria called leptospirosis causing this boy's illness. And they were able to target the right antibiotic, and he too was able to walk out of the hospital. And there was a beautiful picture of him, in the front of his home that was on the front page of the New York Times, and just emphasizing that this is really the new generation of how such diagnostics are likely to work going forward. Here's another example from our team over at San Francisco General Hospital of a woman who had a meningoencephalitis. You've seen some brain MRIs earlier today. What you can see here is that all of these areas are abscesses. These are infection in the brain. They shouldn't be there, and this is all inflammation. Again, using that targeted approach and covering empirically, meaning your best guess, saying we're going to treat for bacteria, we're going to treat for known viruses, we're going to treat for funguses, we're going to do our best to treat the patient while we try to figure it out. Even did a brain biopsy, and we see inflammation of the blood vessels, something called a vasculitis, which can also be autoimmune or infectious. And using this technique, we were able to see through our colleagues in the research lab that there was an amoeba that was causing this brain infection. And with subsequent testing, confirmed that what you're seeing here are actually amoeba in the brain eating the brain tissue. And unfortunately, this patient did not recover, and the family chose to let her die peacefully, and she went to hospice. But I think that this is an example where earlier diagnosis might allow us to identify such problems and be able to target treatment appropriately. And we published this in one of the major neurology journals recently. So these are just examples of how better infectious diagnostics are likely to help us with dementia and encephalitis diagnosis going forward. So I want to switch gears to autoimmune. So we look very hard for infection. And we use clinical judgment to rule out infection. But often we can also use our clinical judgment to say this is likely to be autoimmune. So once we're comfortable saying that this is not an infection, we go down the pathway of could this be autoimmune or cancer associated. And the key discovery over the last decade is this, that there are antibodies that can target brain tissue and cause brain dysfunction. The original antibodies are the model on the left. These have been known about for about 40 years now, and these are called paraneoplastic antibodies. And these are antibodies that target proteins inside neurons. So usually in the nucleus, within the neuron. So these are proteins that are not usually expressed in healthy brain tissue. It's more expressed when a neuron dies. And so what we think actually is happening here is that this is inflammation that's targeting a cancer that also targets brain tissue, and the antibodies we see are a marker of that inflammation. And so when we see this pattern on the left of antibodies, we are worried about trying to find the cancer, either a known cancer or we need to look hard for that microscopic cancer. But we now know that other antibodies can target proteins on the cell surface or in the synapse of neurons. And these antibodies can not only bind, but they can actually change the way that neurons function. So they can change brain function, and they don't necessarily destroy the nerve cell. They just alter it. And that's a good thing if you can get there in time to fix it. Here on the left, these, if you know the antigen, and one example would be if there's a receptor called the NMDA receptor. You genetically engineer these cells to express lots of the NMDA receptor. Then you take spinal fluid from the patient who has a syndrome like this, and you pour it on it. And you see, does it stain NMDA? If you do, that's a good clue that there's that antibody there. Other ways of confirming it is that you can culture, meaning grow, brain neurons from rodents, in this case a rat, And so even if I don't know which protein I'm looking for, I can say, does my patient's spinal fluid stain anything on the outside of that neuron? And if they do, I can use pattern recognition through the knowledge through our colleagues in the neuroimmunology lab to say it's more of this NMDA pattern or this other pattern. You confirm it through the test on the left. Or if not, you might say it's a new disease, a new discovery, but at least we know it's inflammatory. Use your clinical judgment. Maybe we should treat by targeting the immune system. The final way is that you can actually slice the brains of rodents and then take the tissue and stain the brain and see, does it stain? And if you actually see it on 2 or 3 of these, then you have a lot more confidence that you're on the right track. And so this is the way that we test for neuronal antibodies. And this is now commercially available in several major labs and is part of routine clinical care. So the emerging paradigm of CNS antibody disorders is this. Some of them target intracellular, meaning in the neuron, antigens, and those are typically cancer-associated, and that goes under the category of what's called paraneoplastic. The major breakthrough over the last decade are these neuronal cell surface, these autoimmune conditions, which usually are not cancer-associated. They're autoimmune, and they tend to respond really well to immune suppression, the same way we would treat other autoimmune diseases. And there are now other examples of other cell types, myelin, of even A-beta, that protein that is associated with causing Alzheimer's disease, that you can actually get brain inflammation against that, getting an encephalitis in an Alzheimer's type picture. So this, I think, is going to be a model more and more to explain different patterns that we've tried to figure out in the brain and didn't have answers before. So I just want to talk briefly about a couple of archetypal syndromes. The most common of these autoimmune syndromes is the one called NMDA receptor encephalitis. And there have been over 700 cases in the literature. This is an underestimate of how many cases are out there in the real world, but it just shows you how, what's been published. And the classic syndrome here is that this tends to be a disease of the young. And by young, I mean that 95% of cases occur in people 45 years or younger, and a third occur in children less than 18. The classic clinical syndrome is that there tends to be sort of a vague, what you might even call a viral-like, a flu-like prodrome, and then acute neuropsychiatric symptoms. And sometimes these patients even get sent to the psychiatric service thinking that they're having a psychotic break. Then usually there's a rapid progression over a few days to language dysfunction, seizures, and then a subset of these patients progress to coma and have abnormal movements. When you do a spinal tap, you tend to see brain inflammation. Interestingly, the MRI often doesn't show you much, and that's probably because just the physics of what MRI is getting at doesn't pick that up. But we know that these antibodies that target NMDA alter the NMDA receptor and alter brain function. And when you do an EEG, you see evidence of altered brain function. And the diagnostic test is what I showed you earlier. You do the antibody testing from either blood or spinal fluid, preferably spinal fluid, looking for antibodies that target this receptor on neurons. It's associated with a cancer of the ovaries that's usually surgically curable in about half of cases in certain age groups, but the other half, it's autoimmune. Immunosuppression, lowering the immune system, leads to more favorable outcomes when we look back at how patients have done observational studies. And interestingly, in the California Encephalitis Project, in retrospect, when this disease was discovered in terms of the antibody only a decade ago, they went back and said of these unsolved cases, it turns out a substantial proportion of the unsolved were this disease. And in fact, it was actually more common than viral causes of encephalitis in children. That's striking. Recently, we've even seen that there are kids who get bona fide brain viral infection. They have it, it's the correct diagnosis, they get treated, and then a couple months later have a recurrence. And we used to call that recurrent viral encephalitis, but it turns out that some of those kids actually have this disease after the fact. So it's an autoimmune response after the viral infection. And that, I think, is going to give us a clue as to why this might happen in the non-cancer case. Some of you may have seen this book on the bestseller list. So I think this is a real striking term from an author who had this disease, where she described it as her brain being on fire. And I would encourage you to seek her story out if you want to learn more about this. Just recently, in the last month, it was published that a very small, but I think important percentage of women with postpartum psychosis have this disorder. And I think that this is another example of how neurology and psychiatry, the mechanisms of understanding brain dysfunction, are converging. Interestingly, even a polar bear who had a mystery encephalitis that no one could figure out, this was big news in Europe, it turns out now, based on this testing, that the polar bear actually had NMDA encephalitis and died of it. And this is the first example outside of humans of an autoimmune encephalitis. And I think this is, so it's not just a human problem. This is a broader issue of how the brain works. Very briefly, just want to speak about other examples. One is called LGI1 encephalitis. This is, unlike the NMDA story, tends to be more of a disorder in middle-aged and older adults. So often hits when people are in their 50s, 60s, 70s. It tends to be the subacute onset, so weeks to a couple months. So it falls under the rapid dementia paradigm. People have memory loss, seizures, and sometimes have a low serum sodium. There's some unusual seizure syndromes. We also described a prodrome of a bradycardia, a slow heart rate, followed by brain dysfunction. And then it turns out that 90% of these cases are autoimmune, not cancer associated. And some of the cases that Dr. Geschwind was talking about, where they were referred for CJD, for concern about prion disease, in fact had this. It can look like that. And this is much more eminently treatable. And so it's important to get this diagnosis right. And so these tests are now, it's a blood test, are now commercially available. This is all new knowledge in the last decade. Very briefly, there are other examples. The AMPA receptor can cause memory dysfunction. This was a new disease that we were fortunate enough to be part of the original description, where it is actually not just an encephalitis, but also a stomach problem, a GI prodrome with diarrhea. And why is that? Because the gut actually has as many, if not more, neurons than the spinal cord. There are nerves in the gut, and those can get attacked the same way that the brain can. So we've set up this precision medicine model. It's a real team effort. And this is that integration of research, clinical care, and innovation that we hope to be able to move these tests forward to be able to improve diagnosis and improve treatments for our patients. We can treat these conditions with immunosuppressive therapy. The goal is to try to damp down that immune response. There's also some exciting research trying to get at the downstream mechanisms of how the brain malfunctions so that we can target that as well. And then importantly, we need to treat all the symptoms as well to get the best outcomes and to make our patients feel better. I just want to acknowledge all of our colleagues in the MS and neuroinflammation group in the Memory and Aging Center, our patients and their families, my colleagues in the precision medicine unit who did amazing work on the infectious diagnostics, our colleagues who are doing antibody discovery. And this is an international effort with colleagues around the world. And I just want to say, this is the future of science. It's team science, and we're indebted to that. With that, Dr. Geschwind and I would be more than happy to take questions. Thank you.
And I should say, thank you, Jeff, that copies of our slides are on the website, and so you should be able to download those. Questions? So the question was, the abnormal misfolded proteins are binding to the normal proteins and causing them to change shape. How might we treat those? And it sort of depends on... So the question is there a normal process that would repair it? We don't know the answer to that. For example, if I take prion disease as an example, we don't know if prions naturally form and whether they fold and unfold. It's possible that a protein's constantly changing shape. Once it takes on the abnormal shape, we think it likes that shape. It's a favorable energy state, and then the process begins like a domino process. We think that maybe the body recognizes it as foreign and might clear out some of them, but eventually that domino process overtakes the body's ability to clear it out. One of the ways that we think of treating these disorders is to remove the abnormally shaped protein. Another is to block the normal and the abnormal one from ever coming together, maybe with antibodies. And then a third way is actually to remove the normal protein. So maybe as an adult, you don't need that normal protein, or you can live with a lower amount of that. And each laboratory is working on a different approach. My colleague John Collins in London, a Prion researcher, he believes that he can decrease the normal form of the protein, the prion protein, and that a person would be okay, and you might be able to treat disease that way. And one example of that is you can remove that protein from a mouse, the normal protein, and the mouse has a normal lifespan. Only when they have subtle deficits, but they're subtle. A question over here in black. Yeah, so the question was, how do we define slow, medium, fast disorders? And what was the second part? Could a sudden onset ever cause? So,
could a sudden onset ever cause a progressive disease?
You want to answer that?
I'll take the second part first. So normally, no, unless there's new strokes or ongoing strokes, or if there's ongoing seizure activity. So that's an important clue, whether the deficits, meaning the problems, are static or whether they continue to get worse. And that goes with that detailed history taking. In terms of the time course, we tend to describe fast, as Dr. Geschwind said, within days, weeks, and months. Subacute is that weeks to months, and slow tends to be more on the order of years. Using the example of, the classic Alzheimer's presentation would be memory problems over the course of in retrospect, slowly progressing over the last few years.
There was in blue? Yeah. Yeah, so I'll answer part of that, and Dr. Gelfand can as well. So the question was, because we can find things in spinal fluid, should normal, healthy people have their spinal fluid evaluated? And a few years ago, I would have said absolutely not, and I still probably would say that, but there are disorders such as Alzheimer's disease, as you will hear about in the coming weeks through this course, where there are certain biomarkers that are abnormally elevated or low in the spinal fluid that are a marker for Alzheimer's disease. And if there were, we wouldn't screen the population for this by doing spinal taps on people, but if somebody comes from a family where there's a known risk of Alzheimer's disease, perhaps we would want to, and we had a treatment available, we could actually intervene and do something, then not today, but in the near future, we might be doing spinal taps on these people and looking at proteins. But there are other methods we're using now. We actually have PET imaging where we can actually bind, we have ligands that can, antibodies and other small molecules that can bind some of the proteins that I've discussed. And we can actually just do a PET scan and see where the protein is in the brain and how much protein there is. And a normal healthy person shouldn't have a lot of Alzheimer's protein. If I'm 60 and I have a lot of Alzheimer's protein, that probably means I'm at high risk. So spinal fluid, PET imaging, we're going to begin to find markers. And then over here.
And then just very briefly, for these antibodies, the answer is no, not for normal healthy people. We think that the ones that are important clearly cause disease. So this is a diagnostic test for people that are symptomatic. That said, when we have neurologic problems that where this is on the list of possibilities, we highly recommend spinal taps.
Great questions. Thank you very much for your attention.
Thank you very much.